Hi everyone. So beginning with the next chapter of systemic pathology, and that is the breast pathology. Now all of you know that this chapter requires not only your knowledge from path but also alongside we need to discuss and we need to integrate this with surgery. So my advice as always would be, whenever you're doing such chapters that require integration, it is always better that you side by side simultaneously go through the topics that are important in medicine and surgery respectively. On that note, let's begin, and before I start, I think it's very important that we go through the first basic unit, and that is the TDLU. For those who are unaware, what is a TDLU? TDLU stands for Terminal Duct Lobular Unit. It stands for Terminal Duct Lobular Unit. So of course I'm going to talk about something that is going to comprise or happen in the terminal ducts. After that we are going to talk about something that is happening in the lobule. So when these two things will be put together, we will be talking about terminal duct lobular unit. Okay, so before I go into what I see over here, if I zoom in a little, I think you'll be able to see we have the nipple areola complex, and what arises from the nipple areola over here is the lactiferous sinus and the lactiferous duct. So what we have over here is the lactiferous duct. Now on that note, what is going to go beyond it, that we will understand. We can see that there are a set of ducts that are going, right? There's something called a terminal duct. So what are these set of ducts? For that we would have to zoom into it, and that is what I've got you a second picture of. So you can see from here that the lactiferous duct is coming, and how is it dividing? So if you notice, I'll just take up this much of the segment of this particular slide, and you can all visualize that this part is one duct. Which part of the duct is this? This is the extralobular terminal duct. So see, it's definitely a terminal duct, but it's outside the lobule. What lobule am I talking about? I am talking about this lobule which we've marked in the dotted line. This area that we've marked over here, this is going to be the lobule. So whichever duct is outside the lobule becomes the extralobular terminal duct. So this becomes the extralobular terminal duct as you have. And what would be present inside? Of course, the part which is present inside will become the intralobular terminal duct. So have a look at it over here. Can you see the part that is present inside the lobule becomes the intralobular terminal duct? So I can now say that when I'm talking about terminal duct lobular unit, I know that lobular is something which is a lobule. I can see this lobule which I have highlighted for all of you. And when I'm talking about the terminal duct, this terminal duct has two parts. It has something known as the extralobular terminal duct, and it has the intralobular terminal duct. So together it's going to be known as the terminal duct, and then there is a lobule. So everyone's clear with what the ducts are, extralobular, intralobular, but now we need to know what is this lobule that I'm talking about. What exactly is this lobule? So you can see that these lobule is going to have a lot of these sacs or acini. There are a lot of acini that are going to be present inside the lobule. So bunch of acini are going to make up the lobules. These small structures, these bunch of acini, they are going to make up the lobules. So I can say that I'm going to talk about a lot of diseases where the number of acini per lobule will matter. Suddenly we will realize that the number of acini per lobule will increase, and I'll talk about a disease called fibrocystic disease in a while, where these acini, these bunch, that grape-like bunch that you're seeing, that is going to increase. So let's do a very quick recap about whatever we studied up till now. Whenever I'm talking about a terminal duct lobular unit, first I have to look at the lobule, and this is the lobule part. The lobule has what? The lobule basically contains bunch of acini. Then we come to the terminal duct part. The terminal duct part has two parts, extralobular and intralobular. So I can see over here there is one part of the duct which is outside the lobule, which is extralobular. One part of the duct is inside the lobule, that is intralobular. So yes, these two lobular parts are done. Now what you need to know, I've completed the terminal duct lobular unit, but I've only spoken about duct, acini, lobules. What about the stroma? So if I look very carefully, let's now take for example that this is one lobule, I'll label it as L, and this is another lobule. Okay, so there are multiple lobules present. So where all do you see the stroma? I would realize that some part of stroma is inside the lobules. Every lobule has stroma inside it. So what would I label this as? I will label this as intralobular stroma. It is within the lobule. inside the lobule, the stroma that is there, that is intralobular, versus I would also appreciate that there is a lot of stroma in between the lobules. In between also there is space present, right? So what would you want to call this? This I would call as the interlobular stroma. I would refer to this as the interlobular stroma. So yes, on that note, we have something inside, that stroma is intralobular. The stroma in between is going to be the interlobular. On that note, finally, all your TDLU and stromas are done. And why is this information important? Because now I will tell you some tumors and origins of a lot of things that are going to come across. So coming back to this diagram, I think everyone has understood what the TDLU is. I also assume that everyone has understood what the stroma is, because now I'm going to ask you, what exactly was the stroma? The stroma, what do you think the breast has? The breast has nothing but fat, right? So the stroma was nothing but adipose tissue. When I say adipose tissue, it basically refers to fat. When I say adipose tissue, it has fat. So now I actually want to make you revise something. If you go back and you study, I have told you 3 organs which have a similar situation. There is the breast, there is the prostate, and then there is the endometrium. What is common between these? There's definitely a male-female difference between them, but what is still common between them? All of them are going to have the presence of glands. Glands are going to be present in all. This means, how will I differentiate? I will differentiate them on the basis of the stroma. What do you think the stroma of the breast has? Breast has a lot of fat, so it's going to have adipose tissue. Prostate has a muscular stroma. We call it a fibromuscular stroma. See, prostate has to, put out a lot of secretions, so it needs muscle, fibromuscular stroma. And endometrium has a regular stroma, but there's a very important marker for that stroma that I have taught you, and that is CD10 positivity. So please remember, the breast has fat tissue, that is fibrofatty stroma, prostate has muscle, fibromuscular stroma, and endometrium is going to be CD10 positive. All the way coming back, we are done with our breast basic. We've done what is TDLU, we've done what is stroma. Now this was all anatomy part. Now it's time that we go into the histology part, the real pathology and histology that we need to know. So we'll first start with our story of the markers. Remember, I told you that all the breast tissue has glands, which you are calling as terminal duct lobular unit, TDLU. If you actually sit and draw out those, you will realize that there is one row of cells which is on the inside. These row of cells are referred to as the epithelial cells. Obviously, all the glands have something common, and that is referred to as the epithelial cells. But at the same time, they also have a set of cells which are supporting it from here, and that set of cells is referred to as the myoepithelial cells. This is referred to as the myoepithelial cells. So how will I identify in the paper that what are they talking about? I will use some markers. Please remember, epithelial cells are cytokeratin 7 positive, CK7 positive, and actually guys, go back to your neoplasia chapter where we studied the CK720 profile. Over there I had told you that all female related things had the lady luck 7 positive. All females, lady luck, female tumors like cervical cancer, endometrial cancer, breast cancer, I told you they were all CK7, lady luck 7 positive. Okay, coming to the outer cells, because my focus is actually always going to be on these cells. My focus will always be on these myoepithelial cells. You know why? Because till the time they are present, I am talking about benign situations. I am talking about benign conditions. Maybe it's a fibroadenoma, fibrocystic disease, or whatever it is benign and happy till the time they are there. When they're not there, when they go absent, that is when I am going to start having a worry. So that is going to be a malignant. I always make a joke out of it, and these cells, because the same story you must have studied in prostate also. Till the time the outer layer is seen, you are happy. When it's not seen, that is when you're worried that, oh my god, where did it go? If it's gone, it's cancer. So I always say this outer layer is like a lizard. So there's a famous joke that till the time you're seeing the lizard, you don't have to be that scared. But suddenly when the lizard vanishes and you don't know where has it gone, that is when you have to be scared. So till the time you're seeing them, it is whatever it is manageable, benign. But when you stop seeing them, that is when you have to worry. That is when you have to think of cancer. So what are all the markers that we have for myoepithelial cells? Because their presence or absence is the deciding factor, right? So please remember, these are the markers. They include cytokeratin 5 and 6, P53, SMA and S100, and you've read a similar story because in prostate also I told you to delineate the outer cells you needed P63. So the same story coming up here as well. CK56, P63, SMA and S100, these are all positive in the outer layer. So many markers for outer layer because that's the deciding factor. And what is it for the inner layer? For the inner layers you have CK7. So that is your basic marker. Now can we start off with the diseases? I hope yes. So the first disease or the set of diseases that I want all of you to know are the inflammatory disorders. So beginning in that order, we'll be talking about acute mastitis, then duct ectasia, lymphocytic mastitis, granulomatous mastitis, Zuska disease and fat necrosis. That's a topic list that you have to cover, and there are very limited points in each that you need to know. So the first one that I'm starting with is going to be the acute mastitis. What about it do we have to know? So now guys, whenever there is a female who comes to you with this kind of a disease, there will always be a history of breastfeeding. That's the first thing, because when the child is feeding through the mouth, there can be some bacteria that can cause a disease or they can cause an infection over here. So basically via cracked nipples and by the child breastfeeding, definitely there can be an infection that can travel up the lactiferous duct, and that infection very commonly results as an abscess. So imagine that infection from the child's mouth will go and will form an abscess over here, and that is most commonly an abscess formed by Staphylococcus aureus. What else can happen? Because it's related to the skin and soft tissue, cellulitis can also happen, and that has been associated with streptococcus. So there are two bacteria that you have to know. From a breastfeeding child, first you have to consider the Staphylococcus aureus for an abscess, and second a streptococcus for cellulitis. Coming to the next, so acute mastitis done. Now we move on to the next one, and that is going to be duct ectasia. First you need to understand what is the meaning, starting with duct ectasia. What is the meaning of the word ectasia? Now ectasia used anywhere in path, medicine, surgery. Ectasia by default will mean dilation. That means if I say there is, for example, there is over here I'm saying duct. Whose duct? Lactiferous duct, mammary duct. So there is a dilation of the lactiferous ducts that you're seeing over here. If I would have said bile duct ectasia, this means the bile duct was getting dilated. If I would have said something like telangiectasia, then what is getting ectasia? What is getting dilated? Angio is getting dilated, blood vessel is getting dilated. So there is some dilation that you would be noticing here. Okay, so now for example, again we draw the nipple areola complex and we get to know that there is some dilation that has happened in the lactiferous duct. So you know what will get deposited over here? There's going to be a thick, creamy, pasty kind of a material that will start getting accumulated, dilated space, right? So there's a thick, pasty, creamy material that would start getting dilated, and many a times there might be a discharge also that would come out because of it. There could be associated discharge, and that discharge is exactly, so you know the female will come to you saying there's a whitish, pasty discharge that is coming out of the nipples. So what you have to do whenever a female comes with this kind of a discharge or any kind of a discharge, you make a slide out of it. It's not an invasive process. She's taking out the discharge, you just touch the slide or you take one drop of the discharge and you make a slide out of it, and that is going to show you lots and lots of foamy macrophages. That is what you see in a case of duct ectasia. So there are just 3 words that you have to learn out here, guys. I hope you're with me. Number 1, what is ectasia? The meaning of the word ectasia is dilation. What is the patient presentation? There's a thick, creamy, pasty discharge that the patient comes with, and if you make a slide, what are you going to see? You're going to see foamy macrophages. I hope this is also done. We can move on to the next 2, because these are 2 types of mastitis that we have: lymphocytic mastitis and granulomatous mastitis. So I just want to give you a brief before I start. Remember, when I use the word lymphocytic, there is some element of an autoimmune disorder, because if you go back to your immunity chapter, you will realize that autoimmune disorders have a lot of lymphocytes. Similarly, when you're talking about granulomas, maybe some foreign body has come in. Maybe she has just got a silicone implant. So on that note, we will quickly cover up these 2. When do I consider lymphocytic mastitis? As I said, lymphocytes are the cells whenever any autoimmune disorder comes. So if she's having any autoimmune disorder in the rest of the body, so for example, she's Name some autoimmune disorders like SLE is an autoimmune disorder, Sjogren's syndrome is autoimmune, Hashimoto's thyroiditis is autoimmune. You pick up any autoimmune disorder and you go back and now try to analyze what cell did you see. In Sjogren's syndrome, we saw lymphocytes. SLE, we saw lymphocytes. Hashimoto's thyroiditis, we saw lymphocytes. So, lymphocytes always correlate with some autoimmune etiology. That's very important as a concept. Coming to the next one, what is granulomatous mastitis? See, in our country, as soon as I say the word granuloma and which is the infection that has to come to your mind, it's got to be TB. Of course, tuberculosis has to be the infection. And after that, if you're thinking of non-infectious things, then sarcoidosis. We all know that TB and sarcoidosis, in which TB most commonly shows which kind of a granuloma? TB most commonly shows a caseating granuloma, and sarcoidosis most commonly shows a non-caseating granuloma, right? The third one is silicone implants. Please remember, silicone implant is a foreign body. So can the patient's body respond to it, react to it if a foreign body is kept inside someone? Yes, so there can be a reaction, and that reaction could be in the form of a granulomatous mastitis. So these also seem to be done for us. Moving on to the next disorder, it is known as the very famous Zuska's disease. This gets you a lot of questions both in surgery as well as in pathology. So what do you analyze or what do you understand by Zuska's disease? First, you need to know it's got a lot of other names. One name is known as subareolar abscess. What do I mean by that? So for example, there's again a nipple areola complex. This is always going to be like a lesion below, or whatever is going to happen below the areola. So this is the area in which just below the areola it will come as a subareolar abscess. So what exactly has happened? Why have I written something called smold? Listen to me very carefully now over here, guys. When I say smold, I mean there is squamous metaplasia. Oh, so is it a metaplasia disorder? Yes, there is squamous metaplasia that is present of the lactiferous ducts. There is squamous metaplasia that is seen of the lactiferous duct. So now when I draw the same situation, I will realize that okay, if this was the lactiferous duct which was going from here, it was going to have which epithelium? Lactiferous ducts were supposed to have this cuboidal or maximum columnar. So this was the epithelium that the lactiferous duct was supposed to have. But has it changed? Yes, there has been a metaplasia, there has been a squamous metaplasia that has occurred. So why does a change happen? Now what am I seeing over here? Now there's squamous epithelium present. Why is there squamous epithelium present? Because that has been the result of smoking. You will always get a history of a chronic female smoker. Zuska disease will always be associated with smoking. So remember, smoking and smold. So smoking results in which disease in the breast? Smoking results in the smold disease of the breast. Squamous metaplasia of the lactiferous duct. Yaad rahega, SMO, that is what is common. SMO over here and SMO over here. Smoking causes smold. And after some time, think logically, what does squamous epithelium, for example, what does the squamous epithelium of your skin produce? Keratin. So what will the squamous epithelium over here also start producing? It will start producing a lot of keratin. Can I say there will be keratin plugs that will form, and if there are keratin plugs that are formed, it is going to result in the formation of an abscess. Yes, so then ultimately it will start mimicking an abscess. You will think it is a staphylococcal abscess or it is a streptococcal abscess, because abscess will come with typical features, right? It will come to you with features of redness, with increased temperature, maybe with fever. So you'll think it's some infective etiology, but is it infective? No, it's not infective, nothing to do with infection. It is rather said to be a kind of a smoking etiology. Finally done with this, what is the last disease that we are left with? And that is fat necrosis. Nothing for me to teach you in fat necrosis. Why so? Because we have already studied fat necrosis way back in our first chapter when we were doing necrosis. But still, for a very quick revision, I'm going to revise that with all of you. What do you understand by fat necrosis, guys? Please note, fat necrosis is obviously something to do with fat, and that fat is going to break down. So for example, where is the fat? Right now we had studied there is stromal fat that is present, right? And this stromal fat is now going to break down. So why is it going to break down? It is going to break down because of some kind of trauma. So on the breast, what trauma on the breast? So they will either give you the history of a road traffic accident, or they will say the female got hit by a football while she was walking in in the garden, or she had a collision against some vehicle. So some trauma history will be there, trauma to the breast, and that is why there is going to be a fat breakdown. That is why there is going to be a fat breakdown. And I know for a fact that whenever there is a fat breakdown, fat breaks down into fatty acid, and fatty acid always attracts what? Go back to your first chapter. Fatty acid always attracts calcium. What is the color of calcium? Calcium looks like chalk. Calcium is a chalky white. Calcium is a chalky white, or a chalky white appearance. So basically, if I want to identify that fat has been broken, I should be seeing some chalky white areas, some calcific deposits will be seen. So even after this, there are two very important points. Number one, the patient history. Hint number one in the question, the patient history will give you trauma. Hint number two in the question, the radiologist will mention calcification. Both these things will come together and you will mark a case of fat necrosis in the exam. So hint number one is trauma, hint number two, calcification. I hope fat necrosis everyone's revised, because with that we have finished all the inflammatory disorders. Now going forward, we are going to divide all the lesions of the breast into proliferative or non-proliferative, and we are going to discuss them in detail. Having discussed the basics of breast, now let's go ahead with talking about some main pathologies that we have. So over here, I've got a table, because first I'm going to categorize these diseases into which are the ones which are non-proliferative and proliferative, and then what is their risk of cancer. So look at how the first category goes. The first category says that either these are non-proliferative breast changes or they are proliferative breast changes. And what am I going to tell you on the other side? That with these diseases, what is their risk of cancer? Their relative risk, that is RR, and their absolute lifetime risk of cancer. So let's move forward. When I talk about the non-proliferative things, what are the things that come under non-proliferative? A little bit of hyperplasia. Mild hyperplasia is going to be non-proliferative. Little bit cells have increased. If the duct is dilated, there is no proliferation in that. If there is fibrocyst, there's little proliferation, but whenever there is little proliferation, mildness, that I've put under non-proliferative. So cyst formation is not going to be any proliferation. And if there is fibroadenoma without any complicated or complex features, that can also be added on over here. On the other hand, if I go on to proliferative breast diseases, I will have to divide them into without atypia and with atypia. What do I mean by that? Without atypia would mean that there are no bad looking cells. With atypia will mean that there are some bad looking cells, and more the bad looking cells, more will be the chance of cancer. So remember, proliferative breast diseases without atypia. See, you have to focus on the word proliferation happening. So definitely moderate hyperplasia will have proliferation. Sclerosing adenosis, whenever I use the word adenosis, that by default means proliferation. Intraductal papilloma, OMA, sounding like a benign tumor, of course it will have proliferation. And if there is fibroadenoma with complex features, so remember I told you that till the time fibroadenoma is without the complex features, it is non-proliferative, but as soon as fibroadenoma comes with complex features, it is going to be proliferative. Finally, coming to proliferative breast disease, that is going to be with atypia. Now, till here, there were no bad-looking cells, but finally, I have two diseases in which there are bad-looking cells. And what is that? Atypical ductal hyperplasia. So, atypical word is coming, atypical ductal hyperplasia and atypical lobular hyperplasia. So it's very simple to identify that as soon as the word atypical will come, I will obviously put it under the atypia category. Now, having said that, what is it that I have to know from point of view of its absolute and relative risk? So obviously the first category, the non-proliferative one, is going to have a very least or a minimalistic risk that would be present, just a relative risk of 1% and an absolute lifetime risk of 3%. So 1% and 3%. Now let's move on to the other two conditions in which we are talking about proliferative breast disease. So we would always want to learn one number so that it becomes easier for us. So you can remember it somewhere as around 2% and 6%. That's an average that I have taken. So the relative risk is somewhere around 2% and the absolute risk is somewhere around 6%. Because why I learned it that way was when I go to the next category and I try to learn the relative risk and I try to learn the absolute risk, I can roughly do their doubles. From their 2 and 6%, I can roughly go ahead and do a 2 ka double is going to be 4 and 6 is 12, right? So over a 12%. And now I realize in this entire table, all that I've done is doubling. Please do this table once again with me because you will realize that I was doing doubling all sides. So first in the exam, I'm going to write the three main categories: non-proliferative breast disease, proliferative without atypia, proliferative with atypia that is there. Now after that, for relative risk and absolute risk of the non-proliferative is 1 and 3, double it up. What is the double of 1% and 3%? The double is going to be, double of 1 is 2 and double of 3 is going to be 6. So for the next category, I learned it as 2 and 6%. Then in the next category, I decided to double it up. I've done roughly of 4% and then I've done a more than a 12%. So I hope with learning these estimates, things become a little sorted. Finally, we enter into the pre-cancerous condition called carcinoma in situ, and it is very obvious that this is going to have a tremendous amount of risk, but somewhere is it again a double. So if you double the 4 above, you are going to get an 8, and if you double that more than 12 above, you will get more than 24, which is also the absolute risk over here. So I think this is one of the beautiful tables which unnecessarily has been complicated by a lot of students. So quick revision: non-proliferative, then proliferative without atypia, proliferative with atypia, and carcinoma in situ. This is the sequelae before cancer occurs. After that, you will write relative risk on one side, absolute risk, lifetime risk on the other side, and you will do double. You start with 1 and 3 and rest of the story is simple. So with 1 and 3%, so next becomes 2 and 6%, next becomes 4 and 12%, and next becomes 8 and more than 24, that is up to 30%. I hope this table has become easy because now we're going to pick up some things out of it. The first disease out of these that I want to teach you is something known as fibrocystic disease, which is very, very important when it comes to surgery also. So obviously, if I just go and look at the word out here, there is an element of fibrosis that I will talk about. There is an element of cystic that I'm talking about, right? So there's fibrosis, there's cystic, that is okay. So firstly, when I palpate, how do I analyze that is it a fibrocystic disease? So the first, when a female comes to me, lumpy, bumpy appearance, or you can say palpatory finding. If you have a lumpy, bumpy feel, that is what is characteristic of fibrocystic disease. That is on palpation, and the female is also going to complain of pain. Many a times she also complains of cyclical pain. Cyclical pain means that she would have pain at the time of the menstrual cycle. So during the cycle, she's going to have pain. So remember, there's a lumpy, bumpy feel and there is pain on palpation. Those are the palpatory findings of fibrocystic disease. But when I look at the kind of the pictures I'll see over here, so I'll analyze it again. What is the name of the disease? The name of the disease was fibro. So do I see fibrosis? Yes. The second part of the disease was cystic. So do I see cystic? Yes, I can see cystic grossly also. Means, can you see a cyst over here? And it's very characteristic because can you see that cyst is filled with a fluid? This cyst is filled with a fluid, and because of the fluid, has it got a little bit of a bluish tinge? That is why we call it a blue dome cyst. This cyst over here is referred to as a blue dome cyst. I hope that is okay with everyone. So fibro for fibrosis, cystic for blue dome cyst. So what will I do? I will put my needle into it. The first thing I do for any kind of breast etiology, I do an FNAC. So if it's a fluid, suddenly when all this fluid will come out, don't you think that cyst will just vanish or collapse? If this is a cyst filled with fluid, if I take all the fluid out, it is just going to vanish out like that. So we say the cyst is going to disappear or decrease on needling. As a pathologist, when I do an FNAC, this is something that I always notice. I'm putting a needle and fluid comes out, and suddenly the female is very happy that, oh, that cyst, that lump of mine is gone. That lumpy bumpiness that she was feeling, that heaviness and pain that she was feeling, she feels very happy that it's gone because the fluid has come out. But that's only temporary, because once the fluid will fill again, the cyst will be present again. So only on putting the needle, the size decreases. Now when I try to look at the biopsy, imagine if I would have taken this biopsy out, if I resect it and I look at it under the microscope, what am I going to see? So what is the cyst lining made up of? So on a biopsy, I am going to see the cyst, but that cyst has something called apocrine metaplasia. So first I want to explain to you What do we mean by apocrine cells? Apocrine cells are extremely pink cells. See, everything I agree in pathology is pink and blue, but then we always keep playing between what is more pink and what is less pink. So remember, apocrine cells basically means that it is more pink. There is increased eosinophilic cytoplasm that is present. There is increased eosinophilic cytoplasm that is going to be present. So lot of pink. Eosinophil means pink cells, and if you look a little carefully, you can very well visualize that yes, there are a lot of pink cells that are lining all throughout. But can you also see one more thing, that it looks as if something is being vomited out. Can you see some kind of a projection from these cells into the lumen, some projection, and try to look all around? You will actually realize that all these cells, as if something is pinching and coming out, something is trying to come out. And what is this referred to as? This is referred to as an apocrine snout. This is referred to as an apocrine snouting. Means it's like, if you have water in your mouth and you spit it out, it's something like that. So all those secretions are ultimately going to go here. That is why you are having that cyst. That is why you're having the fluid. That is the reason that you have that blue dome cyst and fluid that you were talking about, because there are cells which are producing that fluid. So simple, guys. When I look at it grossly, I get a blue dome cyst. When I look at it on FNAC, it's going to decrease. All the fluid comes out, the cyst collapses, and on biopsy, I see something called apocrine metaplasia. Finally, I have realized that I have done the cystic element, I have done the fibrosis element, but is there a third element also which is not in the name but is important? Yes, and that is adenosis. Adenosis is what? So you need to know the definition of adenosis. Adenosis means increased acini per lobule. Do you remember I told you that every lobule is made up of that bunch, grape-like bunch? So there will be more of grapes in that bunch, more of acini. So more of acini per lobule is referred to as adenosis. So I can say fibrocystic disease is a combination or a triad of what? Number one, it's going to contain fibrosis, as the name suggests. Number two, it's going to be cystic. And number three, it is going to be adenosis. These three things together make up fibrocystic disease. I hope everyone's okay with this. And what category was it coming under? Fibrocystic was coming under non-proliferative. Let me try and teach you something from this proliferative category, but no bad looking cells, no atypia. Means proliferative breast disease without atypia. Did I tell you something like sclerosis will come under it, papillomas will come under it? Matlab proliferation is happening, but there's no bad looking cells in it. So let's revisit that. Is hyperplasia going to be a type of a proliferation? Yes, provided it is moderate hyperplasia. Provided it is a moderate hyperplasia. After that, look at this papilloma. Papilloma, benign tumor. So is this going to show you proliferation? Of course, yes. In fact, let me finish this off here only. Papilloma in surgery will come across as intraductal papilloma. And please remember, intraductal papilloma usually presents as a subareolar lump. It usually presents as a subareolar lump, and the patient is going to have discharge from the nipple. The patient is going to have a nipple discharge. So the location is only that of a nipple discharge. If there's a lump over here just beneath the areola, of course there is going to be a nipple discharge that would be seen. So very commonly female comes with a subareolar lump and a nipple discharge, and there's a lump just beneath the areola, very commonly intraductal papilloma. Coming to the next, there is something called sclerosing adenosis, where you can easily identify there is sclerosis, and now you know what is the definition of adenosis. Adenosis means increase in that grapes, the acini. And finally, we have something called as a radial scar. Now, radial scar is very, very important, mainly because of its gross findings. So I want to share that with you. When I'm talking about a radial scar, please remember, first focus on the word scar. Where is the scar tissue? So I can see there is a whitish scar tissue in the center. This is known as the central stellate scar. This is referred to as the central stellate scar. So right in the center, there's a scar that is present. Now, before I go on to whatever is seen over here, can you recall for me that where else in pathology have you read a central stellate scar? So I'll start with the breast itself. And in the breast, you guys know for a fact that it is going to be the radial scar. But other than that, can you guys let me know? Other than this, so I'll ask you organ-wise. There is something in the kidney, there is something in the liver, and then there is something in the pancreas. These are the four organs which show you the central stellate scar. So in the kidney, there are two things. One is a benign tumor. Benign tumor is referred to as oncocytoma. And there's a malignant tumor. Malignant tumor is going to be known as chromophobe RCC. Malignant tumor is referred to as chromophobe RCC. Coming to the next, in liver also there is one benign and one malignant. So the benign is known as FNH, that is focal nodular hyperplasia of the liver. Focal nodular hyperplasia, so hyperplasia is benign. And malignant is a cancer known as fibrolamellar HCC. Fibrolamellar HCC, again, fibro word anyway tells you that a scar is going to be formed. In pancreas, it is serous cyst adenocarcinoma that tends to show you a central stellate scar. Serous cyst adenocarcinoma of the pancreas shows you a central stellate scar. So repeating, back to the breast. In the breast, it is radial scar. In kidney, it is one benign, one malignant. So the benign is oncocytoma, malignant is chromophobe RCC. In liver, it is again one benign, one malignant. So benign FNF. So benign is going to be focal nodular hyperplasia. Malignant is fibrolamellar HCC. That is FNF. And finally, in the pancreas, you have serous cyst adenocarcinoma in the pancreas. All of them show you a central stellate scar. So coming back, over here in the central stellate scar, try to put two pictures on top of each other. If this is the gross finding of the central stellate scar, try to match it up with the microscopic finding. So you will obviously see that this area is looking very, very pink. Why? Because this must be the scar. This area must be the scar formation. But what did we see? What did we see? That you can't just have in the breast, you can't have scars. So of course, from the scar, you are going to have glands. But now the problem is that the scar is not like one tissue, round tissue. No, the scar is like a star, stellate. The scar is like a stellate, a star. It's going to send out projections. So in between them, the glands, for example, this pen of mine is a gland. So in between them, the glands will end up getting stuck. So can you see now a little carefully, if you analyze, you will realize that the scar or the stroma has these projections like a star going out, and I can see all these glands which are stuck. I can see all these glands which are trapped inside it. Same way over here, I can see all these glands and ducts which are going to be trapped inside it. So that is exactly how the book describes it. There is a central nidus basically of the scar. There are entrapped glands in a hyalinized stroma, and then you will see projections going into the stroma. That's a very complicated way of writing it in the textbook, right? It's very simple. There's a scar in the center. That scar sends out projections, and all the glands are entrapped in it. That is a radial scar, and all of these findings were coming under proliferative disease. But let me remind you, there was no bad cell. I did not even show you any one cell or mitosis or some worrisome feature. All of that was proliferative breast disease without atypia, because now I'm going to go forward and talk about proliferative breast disease with atypia. Guys, when I'm talking about with atypia, I just told you two things. There is something known as atypical ductal hyperplasia. There is atypical ductal hyperplasia, and there is going to be atypical lobular hyperplasia. Atypical ductal and lobular hyperplasia, yes, these have been associated with chromosome 16 and 17 problems. This is something which I would only suggest that you should learn if you're targeting the higher institute exams. Otherwise, it's not an important piece of information. Chromosome 16 and 17 are the losses and gains that respectively that you have to know for ADH, ALH. But what are they going to progress to? Atypical ductal hyperplasia will go into carcinoma in situ, and atypical lobular hyperplasia will also go into carcinoma in situ. But what carcinoma in situ? Ductal will go to ductal carcinoma in situ, lobular will go to lobular carcinoma in situ, right? So ductal will go to ductal, lobular will go to lobular. That is why we have ductal carcinoma in situ and lobular carcinoma in situ, and they will further go to cancer. So which carcinomas will they go to? Common sense, ductal will go to ductal. This is going to result in ductal carcinoma, and lobular will go to which carcinoma? No points for guessing. It is going to go into the lobular carcinoma. So that's the sequelae. You start with ADH, atypical ductal hyperplasia, going to ductal carcinoma in situ. Till in situ means pre-cancer, and then final ductal cancer. Similarly, atypical lobular hyperplasia goes into lobular carcinoma in situ, and finally there is going to be lobular cancer. So now, before I go into the cancers, I want to give you a reminder. And that reminder was that till the time you were not having a malignant condition like a ductal carcinoma or a lobular carcinoma, Do you remember what cells were going missing and then I was scared? Reminder was that in carcinomas, which cells were missing? The myoepithelial cells go missing. In carcinoma, the myoepithelial cells are going to go missing, and or in other words, the myoepithelial cells are going to be absent. Okay, having said that, now we are ready. We have done all of our table that we had to study over here, and we've reached DCIS and LCIS. In fact, we'll talk about DCIS and LCIS in more detail because we are now ready to move ahead with our journey of cancer. So let's begin with the breast tumor classification and the individual cancers under this.